कोई नहीं, तब तक हम
The
थोड़ा माहौल
recording is
बनाएंगे।
on, sir.
अच्छा, ठीक। So we welcome you all from on behalf of IAP Delhi and Government of NCT of Delhi for this very important initiative, which has been primarily taken by Dr. Abhishek Pratap Singh from government. And the objective is that all of us, all pediatricians, medical officers, and people, residents, everybody who's joining today's session, we are able to upgrade our knowledge, understanding of heat-related illnesses, and specifically for children. As you know that right now, Delhi and the most part of the country is going through very scorching heat phase, in which the temperatures are touching some places at 45, 47 degree also. And as our diverse country, many of our people who are living with not much of facilities may be facing a lot of heat related issues, which can lead to a lot of medical illnesses. So to upgrade our knowledge to tackle these issues and ultimately to improve the health of the nation, and specifically for pediatric health, this initiative has been taken, and IAP Delhi is very happy to co-partner this initiative. So I welcome you all, Dr. Vivek Diwan, Dr. Abhishek Pratap Singh, Dr. Ajay Kumar Gupta, Dr. Sham Meena, Dr. Dinesh Goyal, and others, Dr. Romit Saxena, Dr. Shalu, on this platform. And to start the proceeding, I request Dr. Sham Meena, who is the Secretary of IAP Delhi, to take the initiative and start. Over to Dr. Sham Meena, sir. Dr. Yeah.
ज्वाइन करो सर। सुशील, डॉक्टर सालू सर को हेल्प करो, उनको प्रॉब्लम हो रहा है।
Okay, sir.
डॉक्टर श्याम, आप टेक ओवर कर लो। हाँ जी।
Hello, very good afternoon to all, and continuation of our IAP Delhi president. Definitely, we all are the pediatricians. Majority of the pediatricians we aware about the importance of this topic, because nowadays not only like North India, in the various part of continuation of that, the Delhi please representative of Delhi government, they make the alignment with the IAP Delhi, and we scheduled that activity. Or aim of this activity to sensitize our healthcare worker, including medical officers, resident, pediatrician, as well as paramedical staff, to sensitize about that heat related illnesses. In continuation of that, I would like to invite I hand over to Dr. Abhishek as a Dr. Abhishek.
Yeah, Dr. Abhishek is here. Yeah, please.
Dr. Abhishek?
Dr. Abhishek, you can take over now. Dr. Abhishek Pratap Singh.
I think some of the communication. I would like to invite the Directorate of Family Welfare, ma'am, to say the few words regarding these activities.
Over to Dr. Abhishek. I think, yeah, Dr. Abhishek, please.
Ma'am will be joining shortly. She had some urgent meeting. Secretary.
Then we can start the program.
Thanks.
Then I would like Dr. Salu join करली. I would like to invite our first felicitator, Professor Dr. Salu. Sir is a director and professor in Krauti Children Hospital and looking the critical care unit. So, sir, today they are going to talk about the type of the heat-related illness and differential diagnosis in the pediatric age group. Over to Dr. Salu.
Yeah, good afternoon all. Am I audible, Dr. Shyam?
Sir, yes, sir.
Yeah, you're audible.
Okay, right. Thank you. So, should I first start sharing my screen, I think?
Dr. Shalu is a professor of pediatrics at Kalavati Children's Hospital, and is the ICU in charge over there. And he's also a trained balls and pulse trace course trainer. So he is dealing with most of the emergencies. So he'll be taking this issue of heat-related illnesses.
Ajay sir, please introduce the rest of the moderator, Dr. Dinesh and Dr. Sandeep.
along with me, I'm being joined by Dr. Dinesh Goyal. He is the Treasurer cum Secretary elect IAP Delhi and President of IMA West Delhi branch. We welcome him, and also Dr. Sandeep Rawal. He is President IAP North Delhi branch. Welcome him.
Thank you, sir.
sir. Thank you so much.
Over to Salu, sir. Request to all participants kindly put the question in the chat box if you have any queries.
Screen is visible, Dr. Shalu. Please go ahead. Full screen हो गया था बीच में. हाँ, that's great.
Yeah, now you can start, please. Welcome, Dr. Sandeep. Also, is also joined Dr. Sandeep Rawal, President of IAP North Delhi. Dr. Shalu, you can start. You're on mute.
डॉक्टर शालू आपकी आवाज नहीं आ रही.
Dr. Shalu mute पे हैं, हाँ.
एक
I think till the time Dr. Shalu joins, Dr.
मैं
Abhishek.
उसको
Madam,
is here.
yeah, you can. Yeah.
Ma'am,
Dr.
if
Abhishek,
you
you can
want,
take over for some time. Yeah, you can request Madam to say a few words.
ma'am,
Yeah, so very good afternoon to everybody. And I am Dr. Radhika, recently joined as the director at DFW. We are all meeting for the first time. So I am incidentally a gynecologist. I was at UCMS and GTB for the past almost 33 years. And now I find a lot of activity going on, and one of those is the heat related. With every change in activity and season and everything, things change. So Abhishek has been working hard, and he's duly supported by everybody. I'm very glad to see. And I can see today's session is very well planned, and the topics are extremely pertinent. So I wish you all the success, and please, without be spending too much time, let's start the session.
Thank you so much, ma'am. Now I request Dr. Shalu Gupta to start the presentation.
Right, sir. Sir, am I audible now?
Yeah, you're audible.
Yes.
Right. Thank you, sir. Thank you. So,
Yes,
right
yes.
at the outset, I'm really thankful to Delhi IAP, Dr. Pankaj Garg, Dr. Shyam Sundar Meena, Dr. Ajay Gupta, Dr. Anurag, and many of the colleagues of IAP who has really worked hard and given me an opportunity to present a very important topic, especially considering the heat-related illnesses and the temperature environment which is occurring nowadays in India and subcontinent. If we talk about objectives of this presentation, I would briefly be touching about the definition, pathophysiology of heat-related illnesses. Important thing is we should know why are really kids or children susceptible to these kind of things. What makes them more susceptible? What are the different types of heat-related illnesses and the DD we should keep in mind? So heat-related illnesses basically refers to a clinical spectrum. Mind you, it's a spectrum of disorder. It's not a single clinical disease per se. It's a clinical spectrum of disorders which results from exposure to excessive environmental heat. And followed by the exposure, the body is unable to effectively regulate this heat. So there is a continuum of things which are happening, which relates to a broad diagnosis, which is called as heat-related illness or HRI. Now, why is HRI actually occurring? And we all know that with increasing global warming, extreme weather events, increasing heat waves, the things are getting worse. On top of that, there is a disruption in regulating the body's temperature, which commonly occurs as the temperature rises. So the normally heat input from the environment occurs when the metabolism of the body is increased through various mechanisms, and many of these mechanisms, as the heat increases, are disrupted. So when do we call it as heat wave? We have often heard this term commonly that a heat wave is expected or heat wave is running. So whenever the maximum temperature of any station reaches at least 40 degrees for plains, 37 degrees for coastal areas and 30 degrees for hilly areas, we possibly start thinking that it is the onset of heat waves. If we talk about in absolute terms of increase in temperature, then any temperature more than 4.5 degrees to 6.4 degrees above normal is considered heat wave, and more than 6.4 degrees Celsius above normal is considered as heat wave, is called as severe heat wave. If we talk about actual maximum temperature, I think whenever the actual maximum temperature crosses 45 degrees, especially for plains, then we should start thinking that there is an onset of heat wave, and more than 47 degrees, then we should start thinking of severe heat wave. So these are just simple cutoffs given to objectify what is the severity of heat illness or heat temperature. Mind you, all these criteria should be met at least 2 stations in a subdivision for at least 2 consecutive days before we actually call it a heat wave or a severe heat wave. Now, a little bit about pathophysiology. Why this heat waves cause disruption in regulation. So our body temperature, as we all know, is regulated by the hypothalamus and maintained within a constant temperature. This is a property of mammals, which we all know. But as the body's core temperature begin to rise due to any reason, like it may be because of exercise or maybe exposure to an increased environmental heat, the body starts shifting from the storage to dissipation manner. And when this starts occurring, there are several thermoelectroregulatory processes which start occurring. But many of these processes, though effective initially, may become ineffective as the environment temperature increases. So this slides very classically tells what are the common regulatory systems which are start occurring, especially the skin and the visceral organs. There is a process of acclimatization which occurs where there is production of sweat, there is increase in cutaneous blood flow, the aldosterone is activated. All of this would lead to the heat dispersion by various mechanisms. We know that conduction, convection, evaporation, and radiation are the common processes by which heat is dissipated. But later on, it is only the evaporation which starts working, and that too is hampered as we go, as the temperature increases. During these responses, there is release of various cytokines as well, and I'll be telling you what these cytokines do. So there is vasodilation, there is increase in heart rate, there is increase in stroke volume, there is increase in cardiac output. The blood tries to move peripherally for the sweat production and evaporation. I told you evaporation is the sole mechanism which starts occurring as the heat wave increases. And subsequently, because of the blood which is moving peripherally, the steal phenomena occurs and the visceral organs gets less perfused, especially if you talk about the CNS, the kidneys, and the gut. So there comes a concept of what is called as critical thermal maximum temperature. I think we should all know these terms. This is the temperature or the core body temperature that is lethal to an animal. And for humans, this temperature is somewhere around 106 to 107 degrees Fahrenheit. If we talk about in centigrade, it is somewhere around 41 to 42 degrees centigrade for a period of about 1 to 8 hours. So if this temperature is there, the core body temperature, I think this is quite dangerous for the body. So this is what is happening when the external heat is increasing. And these are the compensatory mechanisms. There is insufficient brain perfusion, there is a loss of salt and water, there is dehydration, there is hyponatremia. Later on, because of hypovolemia, because of loss of fluids and electrolytes through the body, there is circulatory shock, which leads to heart failure. And then all of these is a continuum of heat-related illness, which will be just enumerating in few slides later on, starting from heat intolerance to heat syncope, cramps, exhaustion, and finally heat stroke, which is a medical emergency. So this is what is actually happen if we talk about at the cellular levels. There is inflammation in the muscle levels, release of lot of cytokines, including TNF-alpha, interleukins. Also in the intestines, there is release of endotoxins. If we talk about blood vessels, the endotheliums are damaged, and this leads to, again, decrease in many of these biomarkers. which leads to a lot of fibrogen generation and formation of clots. So there is a generalized clot formation. So what similarly resembles is a picture similar to a DIC kind of picture. So when this critical temperature is reached, there is organ ischemia, there is organ dysfunction, there is hypotension, and finally multi-organ dysfunction syndrome leading to death. So in nutshell, if I tell about what actually happens is, if your core temperature increases more than 40 degrees, there is CNS, which is with the CNS dysfunction starts occurring. There is dysfunction of the pulmonary, cardiovascular, hepatic, and renal dysfunction. There is a dysregulation in coagulation, I told you. There is damage to hepatocytes, endothelium. There are changes which starts occurring at the cellular levels. Various proteins, enzymes, and membranes starts getting damaged, denatured. Lot of capillary leakage, systemic inflammation, and all of these finally culminates into a very disaster kind of picture, which is MODS, or multi-organ failure syndrome. So to prevent all these things, the body is developing certain acclimatization. So what does the body do? It increases sweat production. It reduces the electrolyte loss, especially the sodium in the sweat. It increases the skin blood flow during exercises. There is a large stroke volume because of shunting of blood. So the body tries to bring blood supplies to the vital organs. There's an increased aldosterone production, which is again to replenish the loss in intravascular volume, and the decreased, and there is basically a lot of sweating and decreased temperature threshold. So why are kids susceptible? I think this is very important for us to know why are children quite susceptible to develop these heat-related illnesses. There are a few factors which really predispose these children to develop heat-related illnesses. First and the foremost is the small body mass surface area, which these kids are really prone to. They also have a limited ability to regulate their body temperature because of limited numbers of sweat glands initially. The various heat-related stages can evolve very rapidly, and if they are not recognized early, they would possibly be a very fulminant extension of these stages. There is also a higher risk of dehydration, inability to implement common measures to reduce ambient temperature, which these kids make them more predisposed. And it is also important that these are not only something which are written in textbooks. There are studies where people have found that out of all the HRIs or the heat related illness, almost 47, that is almost half of those reported were suffering from heat related illness were actually kids from a study published from US. So it is not fast to say that kids are really susceptible to develop heat related illness. And there is a spectrum of illness. I told you it's not a single entity. These heat related illness is a spectrum which ranges from, say, mild heat rash to very potentially life threatening condition like such as heat stroke. So these are the important, what you say, continuum, starting from heat rash, heat cramps, heat edema, heat syncope, heat exhaustion, and finally heat stroke. And we'll be dealing each of these entities in detail subsequently. So this is a whole spectrum in nutshell. If you see what kids are predisposed to develop in this age group, starting from heat rash to obviously various conditions like heat edema, heat cramps, heat syncope, heat tetany, exhaustion, and heat stroke. So let us start with one by one. So most of these kids who develop heat related illness would have certain common symptoms. I think we need to recognize these symptoms quite early. They would be symptoms such as fainting, dizziness, or weakness, which the kids can explain. There could be nausea and vomiting. There would be increased sweating and thirst. Later on, some degree of cramps would occur. The child would later on probably be acting in a confused manner. And finally, the body temperature starts rising. And when this occurs, I think the stages are quite advanced. So if we talk about various stages, let us start with heat rash. So what is heat rash? We commonly call it as prickly heat, I think. which we pediatricians and general physicians quite commonly see. It is also called as malaria, very commonly seen in young infants during high heat and humidity, and especially all those kids who are lying for a very long time on bed because of lot of sweating and heat. They develop these erythematous papular or vesicular rash, which are primarily due to obstruction of the sweat glands. And these can be very easily seen and identified. They are initially like they're pruritic, benign, and if you remove the heat and the humidity, these rashes mostly are self-limited. The treatment part is supportive, and we need to wear loose garments and avoid overeating. I think the treatment part would be dealt with in the subsequent session, so I'll not be telling much about the treatment. But what I would like to highlight is these are the small rashes which I think we all have seen in our clinical practice, which is just the initial starting stage of heat rash. Then comes heat edema, which is again a very mild form of heat related illness. Here, because of again increasing heat, there is swelling of the feet, hands, and dependent areas. It is usually seen in kids, children, adults who are unacclimatized as a result of vasodilation and venous pooling. Commonly seen in elderly patients, but yes, it can be seen in children as well. Remember, the body temperature is usually normal, and there is no underlying heart failure or kidney disease, which are other common causes of edema. So I think this should be kept in mind that these conditions should not be there before we can actually label it as heat edema. The treatment is again very supportive. You need to do limb elevation, compression stockings, and maybe moving to a cooler environment. And this is actually, you will see how this, you can clearly see that because of this, there is a lot of fullness around the malleoli, and this is edematous limbs of a kid who is suffering from heat edema. Then if we go a little ahead, children and adolescent develop heat cramps. I think many of us has already faced these heat cramps. These are nothing but involuntary contractions of skeletal muscles that occur during or after exercise in a very heated environment, especially if the environmental temperature is quite high. Especially during these seasons, if we do a lot of skeletal exercise, we would often face these heat cramps, and they are very painful. These spasms are very painful, and they usually involve a group of muscles which are actively involved in the exercise. They are usually typically seen in children or adolescents or athletes who are dehydrated, they are deconditioned and poorly acclimatized athletes, and they can be quite painful, as we all know. So there are risk factors. I think we all should know these risk factors. All like who all are really predisposed to develop heat cramps. If there's a prior history of muscle cramps, then I think this kid is really predisposed. Any injury to the muscle, tendon, of ligament, heavy sweating itself predisposes to cramps, dehydration, poor sodium intake during the exercise. Then all of these conditions can predispose to develop heat cramps, especially very commonly seen during these hot and humid conditions in Indian subcontinent. Treatment again is very supportive: rest, hydration, and stretching. And this is what actually will happen during the heat cramps. If you do a lot of exercise during these hot and humid conditions, there is a lot of sweating, loss of electrolytes, and many of these muscles which are actively working will develop cramps, which are quite painful. The next continuum of cramps comes heat tetany, which is again a variant of heat cramp. It is usually characterized by children who are developing rapid and shallow breathing. Again, there is a muscle spasm which occurs often in the hands and feet. There is a numbness and tingling sensations, and there is a classical what we call as carpopedal spasms. There is also dizziness and lightheadedness, which occurs uh, uh, because of changes in the blood flow and electrolyte imbalance. As we all know that the blood is shunted towards the skin, and there is a decrease in perfusion to other vital organs, and lot of electrolytes are lost. So the difference from heat cramps is that there is very little pain usually in these heat tetany. And we need the treatment is that we need to remove the child from this heat and hot environment, calm the child, and probably a role of IV calcium occurs. So this is about heat tetany, and this is actually what happens. The carpal spasm, the classical carpal spasms we see commonly in children presenting with hypocalcemia. Then comes the next continuum is heat syncope. As the environmental heat temperature increases, there is increased vasodilation and venous pooling. And because of this venous pooling, there is orthostatic event starts occurring, because of which there is a brief loss of consciousness, especially seen in individuals who are standing for prolonged period or who are working in very hot and humid conditions for a long time. Mind you, the body temperature is normal by this time. So the body temperature, the body is trying to, what you say, acclimatize or trying to compensate for this increasing heat by various mechanisms, which I have already described earlier. So the temperature is still normal, but yes, there is venous pooling and there is some degree of hypotension which is setting in, which leads to decrease in perfusion of the central nervous system, leads to brief loss of consciousness. Again, the treatment is not normally symptomatic. You need to move to cooler environment, so ensure vital signs, hydration, and ORS. So this is what happens if you are standing or working in a very hot and humid conditions for a very long time. The body tries to compensate for it, maintaining your temperature. But if you do this for a prolonged period of time, then the next stage sets in, which is called as heat injury. And mind you, this is a time when the body is giving you quite signals now that we should start acting. And this is a moderate kind of illness where the body's core temperature now starts rising. So your temperature shoots up from 37 degrees to 40 degrees. And there is a lot of signs and symptoms which are seen in heat exhaustion. There is a lot of thirst. There is a severe headache. There is syncope associated with weakness, vomiting. There is dizziness. Dehydration will occur, and there is a heavy sweating. Later on, tachycardia will occur and hypotension will set in. The important thing to notice in this syndrome is that the central nervous system dysfunction or the involvement of other organs is not there, or it is just very minimal. If at all, if you think about any CNS symptoms, they would primarily include headache and slight confusions, which are usually resolved if you quickly treat them by cooling and rest. Otherwise, the end organ dysfunction or the CNS dysfunction has still not set in at this stage. And this is very commonly seen in laborers and athletes who keep on doing work in this hot and humid conditions with lot of sweating and leading to all these signs and symptoms. So the treatment usually is, again, we have to stop all physical exertion, move to cooler place, hydration, and there are certain cooling methods which would be highlighted in subsequent lectures. Mind you, if this heat exhaustion is not taken care of, then it leads to a very sinister kind of thing, which is called as heat stroke. And this is a medical emergency. So the heat stroke results from total thermoregulatory failures. By this time, the thermoregulatory apparatus of the body was trying to maintain the temperature and trying to provide cooling to the body, but it has now failed and it's a life-threatening condition. And it usually occurs when your core body temperature crosses 104 degrees Fahrenheit. And this is the condition where now the kid would have classical CNS dysfunction or signs suggestive of CNS abnormalities in a setting of heat exposure and strenuous exercise. So he would be developing agitation, confusion, delirium, and finally coma can occur. So this heat stroke can usually occur under two very common conditions. One is when there is very excessive exposure to environmental heat. And second is when the child are exposed to very severe strenuous exercise in a heated environment. So this would usually lead to two classical types of heat stroke. One is called as exertional heat stroke, and the second is called as the classical or the classical heat stroke. So in this, usually in exertional, it is basically the athletes which are predisposed to develop heat stroke, and in classical, it is not the athletes but any other kid who is exposed to a very high environmental heat especially during the heat waves, would develop the classical heat. I think exertional is classically seen in adults and young athletes. However, the classical heat strokes can be seen in any age group, including kids and pregnant women. There are many drugs. I think we'll be talking about these drugs, which can predispose to both exertional and the classical heat strokes. Important thing to notice is risk factors. For exertional heat strokes, which is commonly seen in athletes, dehydration, concurrent illness, obesity, poor cardiovascular fitness, all of these are common risk factors. However, if we talk about classical heat strokes, there is a lack of adequate ventilation, cooling. If you are placed in a congested places, then possibly you are more predisposed to develop classical heat stroke. Mind you, physical exertion is not a prerequisite for classical heat stroke. So all those children, kids, young persons, young adults who even are not doing physical exercise can still go on to develop these classical type of heat strokes. The pathophysiology almost remains quite the same. There is a lot of heat gain, and on the other side there is decreased heat losing capacity. So I think the body is gaining heat because of whatever may be the condition. There is a quick rise of core body temperature over here over minutes to hour. However, in the classical, since it is a slow process, the core body temperature increases slowly over hours and days. The sweating would usually be present, but here sweating may be absent. And since exertional heat stroke is very quick to occur, there's a lot of metabolic changes in the form of metabolic acidosis, hypoglycemia, rhabdomyolysis, liver derangements, renal failure, DIC, and many other electrolyte imbalances will occur very fast. So we have to be very careful in managing these children and young adolescent or athletes who develop exertional heat stroke. Vis-a-vis, if you talk about classical heat strokes, the symptoms and signs are little gradual, though they will develop some of these. Like since they are hyperventilating, they will develop respiratory alkalosis, rhabdomyolysis is unusual, liver dysfunction can occur, renal function can occur, but it is uncommon. DIC would occur, but it is usually very mild. Electrolyte imbalances can occur, and hypovolemia can occur. So there is some degree of clinical overlap, but the clinical sign and symptoms and the severity would obviously be very fast and very severe in exertional heat stroke. So please be very careful in managing these athletic kids or children or young adolescents during a high heat stress environment. So if we talk about in nutshell, what actually is the difference between heat exhaustion and heat stroke? Here the temperature is less than 104 degrees. It has not crossed it, where here your temperature has crossed 104 degrees or the cutoff of 40 degrees Celsius. So there are certain initial neurological signs and symptoms which occur in heat exhaustion. However, here there are severe CNS involvement in the form of seizures, ataxia, delirium, irritability, combativeness, syncope, coma, and finally pupillary changes. The GI systems can also be involved. You will have cardiac tachypnea and tachypnea in the severe systems. A lot of sweating will occur and cramps will occur. All of these are classically seen in heat exhaustion. But in heat stroke, the skin usually becomes sweaty or dry. You can get certain purpuric spots. You can start getting tetany. In gastrointestinal, it becomes a more severe kind of picture where the kid would have hematemesis, hematochezia. There would be signs and symptoms of liver failure and renal failure. So, and in cardiovascular, there would be hypotension, cardiac output failure, high cardiac output failure, cardiac arrhythmias would set in, and finally, I think all of these would lead to MODS. So we should also know what are the risk factors. I think there are environmental risk factors. especially as we all know, very high environmental temperature, lack of acclimatization, lack of air condition, lack of protective clothing, vigorous exercise, all of these predispose these young, gullible infants and kids to develop heat stroke. There are certain physical risk factors as well, just as cardiovascular disease. Any kids who have an underlying cardiovascular disease is obviously more predisposed. Poor cardiorespiratory reserves extremes of ages, in which kids come at one extreme of ages. If there's a previous history of heat stroke, dehydration, obesity is, I think, a risk factor which is seen in many other illnesses as well. Then certain skin conditions can also predispose to develop heat stroke, especially not to forget about thyrotoxicosis, which is a disease which is very commonly seen in young adolescent and younger children. Concurrent viral illnesses and sepsis, I think, are another very important disease processes which predispose these kids to develop heat stroke. Then there is a various other group of drugs, I think, which should not be forgotten. Many of these drugs are CVS drugs. I'm not naming the drugs, but I'm just highlighting the important classes of drugs which can predispose to develop heat stroke. There would be drugs which we act on CNS, which are very commonly used as antipsychotic drugs. There are drugs of abuse, and then there are other drugs which are commonly used as cough syrups and other drugs. So there is a long list of drugs, as you can see, which can predispose or act as a risk factor for developing heat factor. So in nutshell, if I talk about whenever a child develops heat-related illnesses, there are multiple things which are occurring in the entire body. There is increase in blood flow to the skin as a compensatory mechanisms. There is tachycardia, electrolyte imbalances, myocardial injury, hepatic dysfunction, muscle injury, leads to acute kidney injury, DIC, peripheral vasodilation, and there is release of lot of cytokines. I told you initially. Not to forget that the initial symptoms in GIT would include nausea, vomiting, intestinal ischemia, translocations, hypoxemia. Lungs are also involved in the form of ARDS. So if you see, and finally the CNS is also involved. So if you see from this diagram, all the body systems, they are gradually getting involved as the degree of illness or the degree of heat related illness increases. So if we talk about differential diagnosis, I think the clinicians or the physician should be aware to distinguish what are the common causes of hyperthermia. We know that fever is a very normal physiological response to infection and inflammation that causes rise in the body temperature. So usually, but what happens is the body has a very strong thermoregulatory centers in the brain, we all know, and the temperature is usually not allowed to rise below a certain limit. But yes, if the body is having a temperature which is touching these limits or is trying to cross these limits, then possibly we should start thinking of certain other causes, especially heat-related illnesses. But we should also try to look for certain underlying important conditions or the common DDs which we encounter in our day-to-day conditions. I think sepsis we should not forget. Any child who comes to us with hyperthermia, especially if a young infant, sepsis comes one of the first and the foremost differential diagnosis, and we need to rule it out through various lab parameters. Also to look for other CNS involvements in the form of meningitis, encephalitis. Not to forget about drug ingestion, which are very commonly seen in young adolescent. Certain drugs, I told you, and I'll be highlighting some of these drugs. I mean, again, thyroid storm is again an entity where the child can present with hyperthermia. Certain toxins, if ingested, can also cause hyperthermia, especially which are commonly available now in households. Malignant hyperthermia is again an entity where the child presents with very high degree of temperature. Neuroleft malignant syndrome, again an important syndrome. These syndromes can commonly occur when you expose these kids to various drugs. Overdose of certain drugs can lead to various again common syndromes like serotonin syndrome, anticholinergic toxicity syndrome, sympathomimetic toxicity syndrome. Various drugs have various actions, I think we all know, which can all predispose to develop hyperthermia. So this is a common list of drugs I think we have all known which can contribute to hyperthermia. So not mentioning alcohol, which is usually not seen commonly in kids, but yes, young adolescents and adults can have this ingestion and can predispose to hypothermia. Amphetamine group of drugs are very commonly used and misused and abused. Anticholinergics and antihistaminics are drugs which are commonly used in our cough syrup. So be very careful in using these drugs, especially during the hot and humid conditions. Antipsychotics are again drugs which are prescribed for psychotic illnesses. Benzodiazepines are drugs which are very commonly seen in emergency and intensive care areas to control seizures and various other things. Calcium channel blockers, beta blockers are again group of drugs which are very commonly seen in pediatric age groups. Diuretics again forms a very common entity which are used at multiple places in the algorithm of management of pediatric illnesses. Laxative against are quite commonly used. And so many of these drugs, I think we all have encountered and see. So these are all substances that can exactly contribute to hypothermia. So we should all keep this in mind while we are investigating any child who is suspected to have an heat-related illnesses. We need to keep all these differential diagnoses in mind.
Salu sir, please conclude time.
Right. So I'm just concluding there. This is just my, I think, last or second last slide. These are the important danger signs. Any child coming to you with heat-related illnesses, please be very careful if he's having refusal to feed, excessive irritability, decreased urine output, there is a dry oral mucosa and absence of tears and sunken eyes. Involvement of CNS in the form of lethargy, altered sensorium, and seizures are very sinister signs and symptoms, and bleeding from any side. Please be very careful of all these danger signs and seek immediate help. So I think avoidance is the best method, and we'll be talking about in the subsequent slides. And we should always try to stay hydrated, stay indoor, and stay covered. So the key messages are that children are quite susceptible to heat-related illnesses as compared to adults. I have told you earlier. And HRA is a spectrum of illness. It is a spectrum which ranges from a mild heat rash or a prickly rash to a very potentially life-threatening condition such as heat stroke. Mind you, heat stroke is a medical emergency, and it can be differentiated by the presence of primarily involvement of central nervous systems in the form of alteration in consciousness and increase in core body temperature by more than 104 degrees centigrade. Always, when you were seeing kids with heat-related illness, try to look for other important causes of hyperthermia as well. Thank you.
Thank you, Dr. Shalu, for a wonderful presentation. The key takeaway should be prevention of heat exposure. Always carry an umbrella, have lots of water. Do not rely on flavored drinks, because आजकल ना गन्ने के जूस बहुत मिलते हैं. That is another source of infection. Many of the gastroenteritis cases and enteric fever cases, they are related to the unhygienic food, especially the drinks taken from outside. So carrying a simple water bottle and an umbrella will help in most of these conditions. So thank you, Dr. Shalu.
Thank you.
Dr. Sham, you're on mute.
Please unmute.
Dr. Dinesh, Dr. Sandeep.
Thank you, Dr. Shalu, for a very nice presentation. I think you have beautifully described how the kids are more vulnerable to all these injuries. And it is a very important issue, especially in the rising global temperatures, and especially in the summer season, like in our part of area, northern part of area, where we have, such high temperatures. So all those, and the kids are more dependent on parents also. So the public health education, like the today's panel, is a very good initiative, by the IAP Delhi, especially before the summer seasons. And I think it was very well described in your talk. Thank you. Thank you for a very good.
Thank you, Dr. Sandeep.
Dr.
The
Dinesh.
important thing is the identification of the condition and the right line of treatment. Because in our emergencies, even our RMOs are not aware the treatment of the heat stroke, and they are just doing routine treatments. So my intake is that there's a wonderful topic and a wonderful initiative also. And Dr. Shalu is excellent in presenting this topic. And we should organize some workshops or bedside training to the RMOs in the casualty for the heat strokes or the heat related illnesses. Thank you, sir.
Sure, sir. We definitely your suggestion will consider. Before proceeding to next topic, I would like to warm welcome our panelist, Professor Anju Agarwal, madam. She is HOD Pediatrics, UCMS. Now, our second talk is workflow on management of heat-related illness.
Thank you, Dr. Shyam.
Thank you, ma'am. Including severe illness in pediatrics. That our speaker is Romit Saxena. Romit is an excellent speaker and is working as a professor in Maulana Azad Medical College, Department of Pediatrics. And I would like to warm welcome our moderator of this session, Professor Dr. Anurag Agarwal, sir, and Dr. Satish Kumar Meena. Anurag, sir, please introduce of the rest of the moderator and hand over to Dr.
Yeah, so good afternoon, friends, and once again, thank you, IAP Delhi, for organizing a session along with the Government of Delhi on this important topic. Dr. Romit Saxena को introduce करना है. So Dr. Romit is a friend and an excellent who has worked a lot in UK and has come back to serve his country, India, and has done some allergy courses also, and is looking after a lot of our intensive care issues. And if we have a child of heat stroke, definitely from casualty, the child will land up to him. So what else than the right person to talk on the topic who will be managing our heat stroke cases. So with that, I request Dr. Umit to take over. Before that, there is Dr. Satish Meena. He is again Professor of Pediatrics at Safdarjung Hospital. Sir, Director Professor है? Professor है? Director of Professor हो गए होंगे.
He is a professor in looking the emergency services as well as critical care unit.
Okay. So Dr. Satish Meena, sir, would you like to add something or we let Romit continue?
I think we should continue.
Okay. So Romit, please take over and we are waiting to hear from you. Your words of wisdom on this interesting and important topic, the problem which we face in cities like in North India, especially Delhi, Rajasthan, every year. Take over, Romit, please.
Thank you, Anurag, sir. Thank you, Government of NCT, DGHS, and Delhi IAP for providing me this platform to talk about this extremely pertinent issue, which we are seeing in an ever-increasing manner. So I shall be sharing my screen.
रोमित थोड़ी आवाज कम है तेरी आई थिंक या मैंने अपना वॉल्यूम कम कर लिया है
एक मिनट सर मैं शेयर करता हूं मैं एक बार दोबारा शेयर करता हूं
ऑडिबल
इट्स ऑडिबल रोमित
ऑडिबल है
एम आई ऑडिबल सर
वेरी ऑडिबल मुझे लगा थोड़ी आवाज
परफेक्ट ठीक है थैंक्स लॉट सर सो after Shalu sir's excellent presentation, I think he has made my job quite easy, wherein he has described all the cognitive competencies, all of the theory behind the scenes as to why the heat-related illnesses occur. Now we will talk about the psychomotor, कि हमें करना क्या है अगर ये बच्चा हमारे पास आ जाता है. So now imagine it's a scorching July afternoon in Delhi. The sun is relentless, air is like a furnace, the temperature is around 48-49 degrees, humidity is so thick that this your clothes are actually clinging to your skin. So we are all right now in AC rooms, so we can't but imagine in such a thing, there are kids who are actually playing outside. So on such a note, now meet this little girl. She's Jyoti. She's a 3-year-old girl who plays outside every day when her mother is actually a housemaid and she's doing her job. So just like any other day, she was playing on this day when she started feeling dizzy. Her heart started to race and skin became dry and she collapses while she was playing. Lucky for her, a passerby, a nurse, he noticed that Jyoti's face was flushed, her breathing was shallow, and she was confused. Lucky for Jyoti again, this passerby had actually attended this particular session prior and knew that what he was dealing with was a heat stroke. He calls for help and he moves Jyoti to shade and starts cooling her down with water from his bottle. He calls 108 and moves the child to the nearest hospital. So through this particular session, we will decide and understand how to treat Jyoti, what is the approach? What are the rapid cooling methods? What are the supporting care? Suppose Jyoti comes to PHC, what do you do? Suppose Jyoti comes to a tertiary care unit or a quaternary care center, what do you do? And what to advise Asha, her mother, when they are going back? So going on, we all know that Delhi is on red alert right now. Temperature is 6 degrees or more. And so it is a very pertinent topic. And what we also have learned from Ashalu sir's talk is that when a human body is exposed to an elevated temperature for a long duration of time, which is defined as human thermal maximum, 42 degrees for more than 45 minutes or and 8 hours or more. So then the body reaches its break point and the child actually has heat-related illnesses. So Jyoti now has come into your emergency. Her vitals are 180, heart rate, respiratory rate of 48, core temperature is 106. She is flushed and the sensorium, she is drowsy. So we will discuss on how to approach her. So the approach will actually be early recognition. So we have already recognized that this patient has a heat stroke, but suppose this patient would have been brought in by a lay person, the first diagnosis may have been sepsis. So it is important to have a high index of suspicion, weather awareness. Know that though your emergency is a cooled AC environment, you are in Delhi, and it might be scorching hot outside. Measure the core body temperature if you can. The first and most important thing is rapid cooling. Initiate immediate external cooling, and early decision needs to be taken for that, and supportive care. The ABC, whenever we have to deal with any emergency patient, we talk about supportive care and monitor and correct metabolic derangement. So the first step is recognition. So how do we measure the temperature? We all say all the literature describes measuring core temperature from the rectum, and we also know that normally rectal temperatures we don't really use in emergencies, but these are the ideal things because they often allow continuous measurements. But often our monitors don't have the correct probes to monitor a continuous rectal temperature. This is often only available in select ICUs. So axillary temperature we have to know is around 0.5 to 0.8 degrees lower than the rectal temperature. So it is not that if you don't have rectal temperature, you can't work. Axillary temperature is as good, and if your axillary temperature exceeds 40 degrees, consider heat stroke and manage accordingly. And when you're using rectal, please remember the discomfort, potential rectal perforation, all those things have to be known. And this is especially important in the dengue season. Suppose the patient actually has come with dengue, you suspect this, you insert and you cause hematochezia. So it is very important and pertinent that the things have to be taken care of. This is an example of the probes which we have here. So what we had described was how to approach. Now that we know what this patient has, how do we manage? So the most important thing is rapid cooling. Cool the child. The problem was temperature. The answer is cooling. So when do we start? We start it immediately, at least within the first half an hour. Don't delay beyond that. Effective cooling should start at the field. Like in the example of Jyoti, it was started at the field. The nurse put water on her. She fanned the child. She started cooling immediately. How fast do we cool? 1 degree every 10 minutes, not less than 0.078 per minute. So this is the minimum rate of cooling. Till when? We don't need to overcool. So the moment the core body temperature reaches normal 38 degrees, stop cooling. We don't need to go to hypothermia. And if the child is actually going to normal and below, stop. You have already reached your therapeutic endpoint. Now, how do we cool? There are various strategies which have been described in the medical literature, and this is a direct photo from the national guidelines. So depending upon how high the temperature is, you can decide upon the rate of cooling. For example, ice water immersion, this is the best thing, and this can cool up to 0.15. We saw that the minimum was 0.07. The 0.15 is great. So if we want rapid cooling, this is the way to start. What we often see is, हमने बच्चे को AC room में लिटा दिया है, is it enough? So it is important to understand, is putting an AC room enough? No, it is not. If you put in an AC room, it only reaches only 0.02 to 0.06, and you saw the minimum requirement was 0.07. So you need an active rapid cooling method. Just putting in an AC room is not good enough. Going on. So what is the ideal method? So this is again a direct quote from the guidelines. So this in the adolescent patient, cold water immersion is most preferable. In infants and pre-pubertal children, the evaporative and convective cooling is better. So remember, rapid cooling is the most effective strategy for minimizing morbidity. And if we delay it more than 30 minutes, the delay itself can contribute to the mortality. And what we are doing in cooling is we are creating a gradient for heat loss from the skin to the environment, just like we do tepid sponging in fever. It is the same thing that we are creating a gradient, and we need to apply the cooling method depending upon what cooling rate we need to. So this is an example of cold water immersion. So this is the gold standard for all exertional heat strokes and all heat strokes. And this may not be the ideal thing for small kids, because as you can imagine, what you're doing is you're putting a child inside. You don't want the kid to slip inside and drown into it. So this may not be for unsupervised patients. This might be for patients who are athletes. It might be great for adolescents who are big, but for small infants may not be the best thing. It is ideal to use an ice slurry in this, because it will cause a decrease in the temperature, and the gradient will be high between the body temperature to the ice slurry. So how do we go about it? It requires, first thing is getting the manpower together. We need at least 4 people. First person, as you can see, is keeping the person above. You don't want this person might be lethargic and drowsy. You don't want him slipping down and drowning. So one person is holding him up and making sure the airway is maintained. A second person, you can see, is actually monitoring the temperature. Ideally, and this should be a continuous measurement. The third person, this is interesting, is continuously studying the cold water. Now, this studying process is extremely important, because what is happening is, if the water is not stirred, the efficacy of the part of the water which is in contact with the body, if it is not moved, what is happening is the body, because of the high latent heat, the water will take the heat, it will go away, and then the next water will come. This can only happen when the water is continuously stirred. So you can see in this picture, the lady is actually stirring it, and this will help in decreasing actually increasing the rate of fall. And there'll be a fourth person who will be monitoring it. So this is an example of how it is done. And as you can see, this is a photo from a journal, wherein you can see this is an athlete who actually collapsed at the end of a run. And this is how we are monitoring. And you can see the temperature was 106 degrees Celsius. So as you can see, this is often there at the finish lines. So what they're doing is, the tub is around half to 2/3 full. The volume should be enough to submerge most of the area. Prioritize submersion of the torso. The temperature should be around 5 to 15 degrees. There should be ice cooler boxes to put into it. Put it in a shaded area. If it's in the hospital, great, it's already a shaded area. And make sure the safety protection of the providers and the patient has to be done. So this is how we do cold water immersion, the ideal thing, but you should decide your patient. It should not be that the patient slips into it and drowns. Another important thing is, now we know how the temperature is lost. It can be conduction, convection, evaporation, radiation. So most things which we do is evaporation and convection, wherein the water is actually being taking the heat and then evaporating. So this is an example: water spray and directed fan. This is what we do quite often. Here what we do is that it is suitable for older kids and pre-pubertal children. This also, because it's a evaporating cooling, it prevents shivering and overcooling. It is recommended to use tepid water and then we place the patient on a flat surface, and we start to decrease it. As you can see, there is a fan which is continuously evaporating the mist of air. We need to make sure that the external clothing is actually removed, and we give water only if the child is conscious. We don't try to feed and cause aspiration. And it is recommended to apply the damp sheets ideally to these areas like torso, armpits, neck, and groin. But recent studies say that you should put it on all over the body. And as you can see, the spray is being put on the body, and it will then evaporate, taking the body's heat, and then cool the body. This is another example where we are using ice pack and crushed ice, water spray, and directed fan. One interesting thing, if you can see, is that there is a roll under the legs. This is actually elevating it to make sure that the blood supply is being directed to the important areas. So there are many other methods which are there, like emergency cooling rooms, bladder irrigations, intraperitoneal lavages, but they are less studied in kids. And the uh, the medical officers in the emergency room may not be comfortable. So use what you have. These are some easy methods that I've described, which can be done in PHC and all hospitals. This is an example of evaporative cooling. This is actually a cooling room where you can see there is a fan and it's going to cause complete cooling. This is a pollen assisted cooling. And this is an example of a heat stroke immersion cooling unit, which was started in RML last year. So they have got dedicated bathtubs and they actually have been teaching it to the graduates. So we can, as Sir was discussing, this is something we can teach to the MOs very easily. So what are the concerns with rapid cooling? So we know now how to manage it, but we also need to know what we need to watch out for. So one important thing is shivering and reflex vasoconstriction, because that will actually increase the temperature. So how to prevent this? You have to use, it is ideally use evaporative cooling, like using water spray and fan, and especially in small kids. And often we have to use benzodiazepines, but this has to be used with precaution, because remember, benzodiazepines will cause drop in sensorium further. So this needs to be used with precaution. We need to avoid using drugs like clonidine, dexmedetomidine, because this will cause bradycardia. Then after we have cooled, it is better to shift the patient to ICU, because the story has just started. All the injury that had to happen has already happened. You may have reduced the temperature, but the injury to the liver, injury to the heart, injury to the kidneys, the rhabdomyolysis is still going on. So all the story will come in. The kid will go into AKI. So shift this patient to ICU. Cooling is the first step. Other story is still remaining. So now let's go back to our little kid, Jyoti. We had cooled her by using evaporative cooling. Now her investigations have come back. As you can see, she's acidotic, polymorphic. She has got leukocytosis. She is having hypocalcemia, has hepatitis. As you can see, the enzymes are in thousands, and having
Hello.
Hello, Romit. Your voice is not audible.
Romit.
Am I not audible, sir?
Now you're audible.
Am I audible now?
Yes,
Now you're
yes,
audible. We
yes.
thought
Should I
we
repeat
lost you.
again?
Yes.
Just last slide. Last slide.
Only
Okay.
only the last line.
This one.
Is it all right now?
Yes.
Yeah. So
Jyoti's
the
investigation.
Jyoti's investigations are back. As you can see, she's acidotic, she has leukocytosis, has hypocalcemia, has hepatitis, and AKI lysis. So how do we? So as I said, the story was just evolving. We had cooled her, but now we had to shift her to ICU. So what is important to understand is, so these kids actually have, Asar had very nicely described this particular diagram. So what is important to understand is, these kids actually have acidosis because of lactic acidosis and AKI. These kids may have hypoglycemia, which because they might not be eating for a long time, they might be drowsy for a long time. For all you know, this is a DKA child. So you have to look at the sugar. Then watch for sodium and calcium. So potassium can be high in rhabdomyolysis. There might be hypocalcemia. And then we have talked about LFTs. As you had seen, the AST, ALT was in thousands. This peak normally occurs after 48 hours, and it might take up to 2 weeks to resolve. Then coagulation studies. Unfortunately, coagulation studies may be abnormal in these kids. And if coagulation studies are abnormal, this actually shows a very poor prognosis. This is because there's a damage to vascular endothelium, and the platelet aggregation abnormalities have already started, and these patients might bleed. So it's a poor prognostic factor. Going on to CBC, we saw that this patient had a little bit of high TLC. This might again be due to concomitant infection, which the kid might be harboring, which has now been increased. And they might have hemoconcentration, because the kid has now dried up after being exposed to so much of heat. They have AKI because of dehydration, rhabdomyolysis, or direct thermal injury. And most importantly, they have rhabdomyolysis. The CPK levels might exceed lakhs, and this might contribute to acute kidney injury. It is important to look at the ECG because not just for the direct myocardial injury, but also because they might have
Romit, please come back.
I think he had some network issues.
Romit,
Some
Romit,
liquid imbalances.
रोमित कैमरा तो ऑफ है ना उसका? कैमरा
हाँ
तो
ऑफ
ऑफ है।
है, ऑफ है।
म्यूट तो नहीं हो गया रोमित गलती से?
नहीं म्यूट नहीं है सर।
hello.
हाँ
Can you
हाँ
hear me?
नाउ यू आर बैक, नाउ यू आर बैक।
Okay, great.
मेरा
So,
नेट आ रहा है, तुम्हारा क्यों नहीं आ रहा? तुम्हारा हॉस्पिटल का है क्या?
हाँ सर, हॉस्पिटल गए।
अच्छा, मेरा कॉलेज वाला है।
go ahead,
वापस से
go ahead.
शुरू हो गया।
आप म्यूट कर रहे हो
अच्छा,
भाई।
कहाँ से शुरू करूँ मैं?
नहीं
हाँ हाँ
इन्वेस्टिगेशन से?
नहीं इतना
Yes.
पीछे नहीं जा। यू वर देयर टिल CPK।
अच्छा ठीक है, तो व्हाट यहाँ तक हो गया था सर?
हाँ
Yes.
हाँ बिल्कुल हो गया था।
ठीक है
लैक्स तक
तो
पहुंच गया CPK। हाँ
जी तो what is important to understand is कि rhabdomyolysis is something very important in these kids, and they might have the CPK enzyme still lacks, and this will directly contribute towards acute kidney injury. So this is what you should, this kind of testing should be done in all patients who come to you. Up till now, what have we learned is that any patient that comes to you, you do rapid cooling and start monitoring for all these things apart from fall in temperature. So these are the things which we need to do. Now, on the basis of this, I will try to bring it all together and try to describe what are the workflow expected from you if you are a medical officer in PHC and if you are a senior pediatrician in a medical college based setup. Am I audible? I think I'll just interrupt to ask.
Yeah, it's fine.
Okay,
चिंता
fine.
मत कर, तू अनऑडिबल होगा हम बोल देंगे।
अच्छा ठीक है सर।
हाँ
तो गोइंग बैक, सो व्हाट अब पीएचसी में क्या करना है? तो इन अ पीएचसी केस आया, फर्स्ट थिंग इज सस्पेक्ट कि ये हीट स्ट्रोक हो सकता है। हर चीज सेप्सिस नहीं होता। इस बच्चे को अगेन, अगर आपका ऑर्डरली देख रहा है, पहले डॉक्टर को बुलाओ। द डॉक्टर हैज टू सी, मेक श्योर द किड इज नॉट लाइंग in the beach में on a stretcher with no fan. Move the patient to a safe, cool, shady environment. Take the vital signs. Make sure start oxygen. If the patient is unconscious, don't give anything orally. Remove all unnecessary clothing, but within limits of decency. Start tepid sponging. Make sure, जैसे describe किया था मैंने, mist, water mist plus fan, evaporative cooling बहुत आसानी से हर बंदा कर सकता है, तो ये आप immediately start कर सकते हैं वहां पे. Spraying cool water and start that. Apply cold compresses to neck, axilla, groin and head, and पूरी बॉडी की भी स्पॉन्जिंग कर सकते हैं आप. एंड अगर आपके पास कोल्ड सलाइन है तो आप कोल्ड सलाइन एक रख के स्टार्ट कर दीजिए. तो एंड व्हाट इज द मोस्ट इंपॉर्टेंट, अल्टीमेटली आप करना क्या चाहते हैं? रेट ऑफ ड्रॉप ऑफ टेम्परेचर कम से कम 0.07 या 0.1 से होना चाहिए. तो आप इसकी मॉनिटरिंग करते रहिए. आप कंटिन्यूसली डिग्री सेंटीग्रेड से जो भी है आपके पास, अगर आपके पास रेक्टल कंटिन्यूस नहीं है कोई बात नहीं, आप एक्सिलरी से कीजिए, बट मॉनिटर कीजिए. नॉट जस्ट the temperature but heart rate, respiratory rate. This patient might become unconscious in the middle of your treatment, might require intubation. तो मेन चीज है मॉनिटर करते रहो. और अगर आप कैनुला लगाओ, इसके सारे सैंपल्स जो मैंने डिस्क्राइब किए थे आप एक साथ भेज दीजिए. शुगर चेक कर लीजिए और वही CBC, CP के सारी चीजें भेज दीजिए. सिर्फ भेजना ही नहीं है, 8-8 घंटे पे आपको रिपीट भी करना पड़ेगा, 8 से 12 घंटे में ये आपका ज्यादा होगा. अगर खराब आए तो और फ्रिक्वेंटली भी करना पड़ सकता है. फॉर एग्जाम्पल, अगर आपका पोटेशियम आता है 8, यू विल नॉट वेट फॉर 8 आवर्स, आपको इमीडिएटली उसका ट्रीटमेंट शुरू करना पड़ेगा. लाइक गिविंग कैल्शियम, लाइक गिविंग इंस्टेंट डेक्सट्रोज, लाइक गिविंग एम्बोलाइजेशन, जो भी रिक्वायर्ड है आपको इमीडिएटली ट्रीट करना पड़ेगा. और फिर उसके इमीडिएटली बाद आपको दोबारा से रिपीट करना पड़ेगा चेक करने के लिए कि पोटेशियम फॉल हुआ नहीं हुआ. एंड अगर आपके पास जितनी फैसिलिटीज आप ट्रीट कीजिए. एंड अगर आपको लग रहा है बच्चे AKI में जा रहा है, बच्चे को वेंटिलेशन करना है, तो यू रेफर हिम टू अ हायर सेंटर. बट रिमेंबर, यू विल हैव टू ट्रांसपोर्ट द चाइल्ड. यू कांट जस्ट लीव दिस चाइल्ड की अपने आप ट्रांसपोर्ट होगा, क्योंकि ऑलरेडी बच्चा बहुत अनस्टेबल है. तो वर्क फ्लो एट टर्शरी. अब ये बच्चा आपके पास आया, सपोज ये जो बच्ची थी ज्योति आपके पास आती है, सीधा पहुंच जाती है. तो फर्स्ट चीज इज सस्पिशन. वी थिंक कि समर सीजन था, टेम्परेचर ज्यादा है, एक्सिली टेम्परेचर, ऑल्टर्ड मेंटल स्टेशन, कंफ्यूजन है, heat related illness or heat stroke is one of the important diagnoses. As sir had said, remember heat stroke is a medical emergency. And in the triage, remember, अगर recent exposure है, CNS dysfunction है, tachycardia, tachypnea, flushing skin है, तो please remember sepsis and drug overuse के साथ heat related illness is also one of your differentials. So how to manage? In the first 5 minutes, recognize, assess your ABC, airway, breathing, circulation, document core temperature or at least documented temperature, consider alternative diagnosis and start definitive treatment. Going on, टेम्परेचर, अब इसकी टास्क क्या क्या है? ये आपने था कि आपको ये जो काम करना था, अब आपको अचीवेबल्स क्या है? टेम्परेचर चेक कर लिया, एक आईवी लगा लिया, मॉनिटर से कनेक्ट कर लिया, और जब आईवी लगाया तो सारे सैंपल्स भेज दिए। अगले 10, तो ये हमारे पहले 5 मिनट में, उसके अगले 5 मिनट में, यानी कि पहले 10 मिनट में क्या करना है? सारे कपड़े विद इन लिमिट्स ऑफ डिसेंसी हटाने हैं, रैपिड कूलिंग इनिशिएट करनी है एटलीस्ट विद इन हाफ एन आवर के बाद तो इट विल स्टार्ट इम्पैक्टिंग द आउटकम। कवर्ड विद अ वेट शीट और स्प्रे कूलर, जो भी आप मेथड यूज कर रहे हो, योर होल टीम शुड नो कि हम ये मेथड यूज करने वाले हैं। आइस पैक यूज कर सकते हैं हेड, ग्रोइन, एक्सिलरी एरिया में, और उसके बाद मिस्ट फैन इवेपोरेटिव मेथड, दिस व्हाट वी यूज एंड दिस यू गाइस कैन यूज एज वेल, द नेशनल गाइडलाइंस आल्सो रिकमेंड। दूसरी चीज, टेपिड स्पॉन्जिंग शुरू करनी है, मेक द किड लाई डाउन विद एंड रेज द फीट, ताकि ब्लड जो वीनस पूलिंग हो रखा है वो आपके वाइटल ऑर्गन्स तक पहुंचे। अब एक बहुत इंटरेस्टिंग चीज है, नॉर्मली एक बुखार आता है, सबसे पहली चीज आप क्या करते हैं? पैरास्टामोल देते हैं, है या नहीं? मगर इस बच्चे में हम पैरास्टामोल एनसेड्स नहीं देंगे। क्यों नहीं देंगे? ये क्योंकि आपका जो प्रॉब्लम है ये हाइपोथैलेमिक इंड्यूस्ड हीट रिटेंशन नहीं है जिसपे पीसीएम काम करता है, इसकी प्रॉब्लम है आपका हीट जनरेशन है, तो इसमें पीसीएम काम ही नहीं करेगा। ठीक है, अब फिर क्या करना है? अगर आपके पास कोल्ड सलाइन है तो आप आईवी फ्लूइड्स शुरू करेंगे, बट रिमेंबर ये बच्चे एकेआई में जाएगा, तो गिव इट जुडिशियसली, वॉच फॉर शॉक। शॉक है तो आपको बोलसिस देने हैं, वही 20 ml per kg एज रिक्वायर्ड डिपेंडिंग अपॉन योर सेटअप, 10 से 20 ml per kg while watching for overload. These kids may have myocardial impairment and they might go into pulmonary edema. तो रिमेंबर, जब आप पानी दे, इसको फ्लूइड दे रहे हैं, लंग्स ऑस्कल्टेट करने हैं, हार्ट रेट देखना है, लिवर देखना है। उसके बाद क्या करना है? अब बच्चे को मेन चीज है, जो भी आप इंटरवेंशन करेंगे आपको मॉनिटर करते रहना है कि इसका रिस्पॉन्स क्या आ रहा है। अगर शॉक है, आपका फ्लूइड देने के बाद हार्ट रेट कम होगा, बीपी इंप्रूव होगा, सेंसरी में इंप्रूव होगा। शॉक नहीं है, पल्मोनरी एडेमा आ रहा है, लिवर रिग्रेस करेगा, क्रेपिटेशन आ जाएंगी, हार्ट रेट बल्कि और बढ़ जाएगा। वाइटल साइंस देखने हैं, आपने रैपिड कूलिंग इंस्टीट्यूट की तो टेम्परेचर कितना फॉल कर रहा है, जो आपका रिक्वायर्ड है उतना फॉल कर रहा है नहीं कर रहा, जीसीएस इंप्रूव कर रहा है नहीं कर रहा, क्या आप ज्यादा तो कूल नहीं कर रहे, आर यू गोइंग टू हाइपोथर्मिया और नॉट, ये सब देखना है, क्योंकि आपको हाइपोथर्मिया नहीं लेके जाना। गोइंग ऑन, फिर क्या है? बच्चों को सीजर आ सकते हैं, तो माइट रिक्वायर अप्रोप्रिएट स्टेटस एपिलेप्टिकस प्रोटोकॉल, जिसमें क्या होता है, पहले बेंजोडाइजेपिन देते हो, फिर आपको लोडिंग ऑफ फेनिटोइन या फिर लोडिंग ऑफ एवेरा आपको देनी पड़ेगी। फिर शिवरिंग अगर हो रही है तो इवेपोरेटिव कूलिंग यूज करेंगे, या फिर आप बेंजोडाइजेपिन देंगे, बट याद रखिएगा बेंजोडाइजेपिन देने के बाद जीसीएस माइट फॉल फर्दर। Look for signs of coagulopathy. Remember, it's a bad prognostic marker. All the samples we had discussed of, like ABG, RBS, LFT, send them. These patients might have intracranial pathologies. Remember, heat stroke is one of the differentials. There might be other things. ये नहीं कि all fever that comes to you is heat stroke. तो आपको अपने बाकी डिफरेंशियल सोचते कि ट्यूबिकुलर मेनिंजाइटिस आ रहा हो आपके पास, तो या फिर इंट्राक्रैनियल ब्लीड आ रहा हो आपके पास, तो आपको सीटी स्कैन भी कराना पड़ सकता है। हो सकता है कि बच्चे को स्ट्रोक, हीट स्ट्रोक करके बेहोश हो गया हो, सिर पे लग गई हो, जिसकी वजह से इंट्राक्रैनियल ब्लीड हो गया हो, तो आपको सीटी करा के देखना पड़ेगा। एंड देन रिमेंबर, इट इज नॉट जस्ट द कूलिंग, द पेशेंट विल रिक्वायर ऑनगोइंग मैनेजमेंट इन द इंटेंसिव केयर यूनिट। So what we did for this particular kid was we cooled her to water spray and directed fan. Patient went into mods, got intubated, and uric AKI हुआ, dialysis हुआ, intubate हुआ, सब कुछ हुआ, और अब हम बच्चे को डिस्चार्ज करने वाले। तो क्या ये दोबारा हो सकता है? बिल्कुल। दिल्ली गर्म रहेगी, दिल्ली में मॉनसून लेट आएगा, तो ये होता ही रहेगा। तो हमें क्या करना है? पेरेंट्स को बता के रखना है कि हाउ टू प्रिवेंट दिस। तो फर्स्ट एड इंस्ट्रक्शन हमको पेरेंट्स को बता के रखनी है। ठीक है, तो आशा ज्योति की माँ है, उसको डिस्चार्ज से पहले हम क्या बताएंगे? वी हैव टू टेल देम दी साइंस जैसे Dr. Shalu sir had already described, if the kid has excessive thirst, weakness, tiredness, fainting, muscle cramps, nausea, vomiting, irritability, this might be heat exhaustion. But if this progresses to severe headache, weakness, alteration of sensorium, unarousability, seizures, flushed, dry skin, temperature more than 105, be alert. This is a medical emergency. This might be a heat stroke. तो इस तरफ बच्चे को लेके ही सीधा क्या करना है, पहले बच्चे को अंदर लेकर आओ, बच्चे को शेड में लेकर जाओ, रिमूव क्लोथिंग, रिमेंबर cooling has to be started immediately, you can't wait for it, remove the clothing while maintaining dignity, make the child lie down because you want the blood to go to the brain, increase airflow using a fan, नॉर्मल टैप वाटर करो, टेपिड स्पॉन्जिंग करो, अलर्ट है तो पानी पिलाओ, अलर्ट नहीं है अनकॉन्शियस तो पानी मत पिलाओ, नहीं तो बच्चा उल्टी करके चोक करेगा, अनकॉन्शियस है डोंट। हाँ सर, बस हो गया, 2-3 स्लाइड्स। हाँ सर, तो प्रिवेंशन क्या करना है, लुकआउट फॉर वेदर वार्निंग्स, गवर्नमेंट ऑफ एनसीटी बहुत बड़ी वार्निंग्स निकालती है, रेड अलर्ट्स करती है, प्लीज कीप अ लुकआउट। अगर आपके रेड अलर्ट्स हो रहे हैं तो मेक श्योर द किड्स आर प्लेंटी आर हाइड्रेटेड। आजकल बहुत सारे बच्चे एलन आकाश जा रहे हैं, मेक श्योर दे हैव अ water bottle with them. Make sure the kids are wearing light colored loose clothing. Remind kids to stay in shaded areas. Make sure 12 से 3 बजे के बीच में avoid activities. Don't participate in heavy activities, especially during this time. Teach kids to come immediately indoor whenever they feel overheated. And do not keep the kids alone. Especially ऐसा नहीं होना चाहिए कि बच्चे को अपने बाहर पार्किंग लॉट में लॉक कर दिया, तो वहां पे ग्रीन हाउस इफेक्ट होगा एंड ही विल एक्चुअली दे माइट go into heat stroke. So take home messages are, heat stroke is an emergency. High degree of suspicion is required on behalf of all medical officers and they should remember इस मौसम में हो सकता है rapid cooling, rapid cooling, rapid cooling. It is the cornerstone of management. Do not overcool. तो टेम्परेचर 38 डिग्री तक ही लेकर आना है, उससे नीचे नहीं लेके जाना है, एंड हॉस्पिटल प्रिपेयर्डनेस इज इम्पोर्टेंट। ठीक है, these are the guidelines which I have referred. I would recommend, these are freely available online. I would recommend all of you to go through them. They are very nicely made guidelines. Thank you. Hoping for quick monsoon.
Thank
Yeah.
you, Dr. Amit, for wonderful presentation. Over to Dr. Anurag, sir.
Yeah. So, Dr. Satish sir, would you like to comment on this, sir? Satish Meena sir.
Yes. So this was a very good and very elaborative case-based management of heat-related illness in children. So most of the time, this is a classical presentation of heat-related illness, and this is how we have to manage the child. The only question is, or an only thing which sometimes strike our mind is whether we are dealing with something like sepsis or heat-related illness. So there are certain pointers by which we can differentiate that this could be sepsis also?
Romit.
Dr. Romit. So I think I was thinking कि
am I audible? Sorry.
Yeah, Romit, अब audible होगा।
हाँ सर, नहीं सर, so unfortunately जो जैसे शालू सर ने बताया था सर, डायरेक्ट एक्सपोजर, अगर आपके पास बच्चा आया, अब दो मैं आपको सिनेरियोस बोलता हूँ, एक 3 साल का बच्चा है, 2 दिन से बुखार है, अभी और बच्चे को ग्रेजुअली ऑल्टरेशन ऑफ सेंसोरियम हुआ, फिर हफ्ते भर से बुखार है, पेट खराब है, लूज टूल्स होने शुरू हुए, अब बच्चे को बुखार आया तेज, 100-104 का स्पाइक आ रहा है, सीजर आया, इंटूबेट हो गया। दूसरा बच्चा है, बच्चा बिल्कुल नॉर्मल है, स्कूल जा रहा था और बच्चा आते हुए एकदम से बच्चा खेल रहा था, एब्सोल्युटली नॉर्मल किड, और बच्चे को खेलते खेलते स्टार्ट बिकमिंग ड्राउजी, बच्चा बिल्कुल फ्लश्ड है, बच्चे को टेकिकार्डिया है, तो आपकी हिस्ट्री ही बताएगी कि बच्चे को क्या है। अगर आपको पता है कि हिस्ट्री कोलैबोरेटिव है, एंड ऑब्वियसली यू हैव इन्वेस्टिगेशन व्हिच कैन हेल्प यू कोलैबोरेट दैट, बट ऐसा नहीं है कि इस दूसरे बच्चे को सेप्सिस नहीं हो सकता, मगर आपकी हिस्ट्री एंड आपका एग्जामिनेशन will help you decide which is it, and ancillary investigation can obviously be collaborative, sir.
Yes, very good, Dr. Romit, this is correct, but I would like to add one more thing is that in our classical teaching, what we are telling the children that temperature gradient. So if you are finding core to peripheral temperature gradient fitting into sepsis, you may consider sepsis as the possibility. But generally in heat related illness, you will have uniformly hot body areas.
Yes.
So, Romit, there is a question from Dr. Dinesh. Do you
जी
have
सर
anything available for cooling of patients in your
सर
setups or
अभी
in
ना
Delhi Common
नहीं नहीं
setups?
अभी वेरी इंटरेस्टिंगली सर मैंने देखा था 2024 में आरएमएल में शुरू हुआ है सर इन डिपार्टमेंट ऑफ मेडिसिन
हम्म।
वो मैंने एक फोटो भी
नहीं
दिखाई
वो
थी सर अभी आपने
वो
हाँ,
देखी होगी
उसके
ना
emergency में
अलावा
है
दिल्ली
रोहित।
गवर्नमेंट।
सर बाकी तो टू बी वेरी ऑनेस्ट अगर एक बच्चा आता है आपके पास जैसे
नहीं
मैंने दिखाया था
नहीं
यू डोंट नेसेसरली नीड अ टब आप कहीं पे भी शुरू कर सकते हैं आपको बेसिक चीज है कोल्ड वाटर कूलिंग करनी है आप हॉट
या
मिस्ट लेके वैसे शुरू कर दीजिए आपको हमेशा ये नहीं है कि इमर्जन करना है तो और नहीं तो इमर्जन करने के लिए जैसे आरएमएल में था व्हाट दे हैव डन इज दे हैव बॉट इन्फ्लेटेबल टब्स जैसे हमारे घरों में होते हैं ना सर टब्स जो हम बच्चों में जिसमें
हम्म।
करते हैं उन्होंने इन्फ्लेटेबल टब्स खरीद रखे हैं और ऐसे
तो
इन्फ्लेटेबल टब्स में पानी भर के आप उसमें भी इमर्स कर सकते हैं मगर
तो
वही है
दैट्स
कि जब
व्हाट।
आप इमर्स कर रहे हैं तो वो 4% टेक्निक वो बहुत ध्यान रखना है और छोटे बच्चों में इमर्जन इज नॉट रिकमेंडेड बड़े एडोलेसेंट्स में रिकमेंडेड है क्योंकि छोटे बच्चे तो पानी में स्लिप कर जाएंगे अनुराग सर
So, that is
So
what I
Dr.
was saying.
Anurag,
When we were
yeah,
PGs, we used to have tubs with us and some ice in the ice box of refrigerators. तो एक आध बच्चा उससे मैनेज हो जाता था. I think we are overlapping time. So,
Dr.
Dr.
Anurag,
Romit, it was a हाँ. We should end. You want to ask something, sir? बोलिए.
नहीं जस्ट मैं जस्ट ऐड करना चाह रहा हूँ कि आर हॉस्पिटल आल्सो लाइक ऑल मोस्ट ऑफ द सेंट्रल गवर्नमेंट हॉस्पिटल्स हैव बीन एडवाइज्ड टू प्रिपेयर सर्टेन हीट बेड्स in their
Mhm.
emergencies,
Okay.
including RML and ourselves, and we have designated 1 or 2 beds for heat-related illnesses, where we
Mhm.
have arranged for a cooling fan, a sprinkler, and ice equipments, and things to monitor core body temperature. So
So
all
That
these.
is good.
in the
That
central
is good, sir.
government hospital include Safdarjung, RML, Lady Harding, all are the facilities are available and likely in the LNJP hospital is also available in the some graded manner.
So, I think we will end the session on this note and an excellent presentation by Dr. Romit and the guidelines that you have to manage body temperature first and foremost, and then look at the investigations and manage the patient accordingly holds true. And with this, I thank the organizers, IAP Delhi, thank Dr. Romit and my co-chairperson, Dr. Sham, Dr. Satish Meena. Thank you, and Dr. Sham, please take over.
Thank you, sir, for your kind word. Now we are the moving on next session. Strengthening of the health system, preparedness for the health related illness in pediatric age group. That will going to taken by the Dr. Vivek Diwan. Sir is a senior consultant and professor, Ram Manohar Lohia Hospital, and unit in charge as well as looking the GI services as a in charge there. And for that, we have the moderator, Professor Dr. Pradeep Kumar Devta, sir. Sir is also senior pediatrician, the head of the Department of Pediatrics, Safdarjung Hospital. And GP Kausal, sir. Sir is a medical superintendent in Madan Mohan Malviya Hospital. And our Sanjay Singh, sir. Sanjay Singh, sir, is program coordinator from the State Health regarding national program on climate change and human health. So over to Pradeep Kumar Devta sir for a brief introduction, rest of the moderators, and over to Dr. Diwan sir after that.
So, uh, without any delay, because we are already surpassed some time,
Yes, yes, sir.
I request Dr. Vivek to first present his presentation, and then we can start discussing about that. Welcome, Dr. GP Kosal sir, Dr. Sanjay Singh, Dr. Surendra Singh Beast. Uh, they are co-moderator with me today, and after this we can have our questions and discussion after the presentation of Dr. Vivek. Dr. Vivek, over to you.
Thank you, Dr. Pradeep, Dr. Shah, and I welcome all, and I'm thankful to IAB for this presentation. Am I audible?
Yes, you are audible.
Yeah, like I heard both the speakers, and they've covered most of the things that I needed to speak because they have just enumerated everything that needs to be present for heat stroke management. But anyways, I'll just revise it again maybe. So while we are preparing for the heat stroke management, the first thing, I'll just show up a case scenario with a 6 months old infant who is having a high temperature and is suspected to have heat stroke. So we need to have preparedness. For in the ambulance itself, we need to be having a monitoring facility for temperature, cooling gadgets like ice packs, mist spray, and portable fan. Because children, where you cannot immerse them into ice water, we need to have mist spray and portable fan for those. And then you can have IV cannula tubing saline to be started, and airway management and emergency truck to be available. So this is what you require in ambulance, which should be there. And this is how we have ambulances in our place, which are especially looking for heat stroke as well. Then when the patient arrives at the emergency, then again they need to be having special heat treatment facility. We have a emergent tub and other facilities in a AC room, which are being set up for monitoring facilities with all the drugs required and lab facilities required. These all have been enumerated by the previous speaker, so I need not address all these. So we need to have all these things as a part of our management of heat stroke. So this is again the same things which have been just mentioned. So this part is slightly left out. I heard the rectal temperature monitoring. Although there are various ways to monitor the temperature, skin temperature, and rectal temperature or the core temperature using esophageal probe, which are not usually available. And as one of the speakers said, the skin temperature is generally used, and we add 0.5 to 1 degrees centigrade as a core temperature for it. But if available, the flexible rectal temperature can be put 10 centimeter deep, and while they're being transported in ambulance, this can be used for measuring the temperature. And the target, as has already been said, that we want to is the slide being changed? Next slide, please. Next, 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 next. So we have done this, and so previous slide, please. Just the previous slide. So the target, as we already said, that the target is to achieve everything in first 30 minutes. And the gold standard is cold water immersion, or the evaporative methods are less effective. And the next slide, please. Next, please. So this is next, please. This is just a table showing the various cooling method. And as we see, we require to cool down by 0.1 to 0.2 degrees every, 10 minutes. We need to decrease by 1 degree. So at least 0.1 to 0.15 in every 2 to 3 minutes. So if we see at this, in the cooling methods which are most effective are related to immersion only. And the ones down below are just decreasing it by 0.05, which are like sheets and jackets and fluids and fanning and all. So the children who need to be immersed actually may not be immersed and have to be using the evaporative method, where the cooling is not as rapid, but due to a higher surface area, they may still be able to achieve a rapid cooling. Next, yeah, supportive care. Previous, please. Previous slide. Yeah. So again, this is the same slide. As I said, the various other treatment methods have been already enumerated, and also the investigations. Next, please. So the complications have also been addressed. Next, please. Next, please. So this part has already been addressed, that while the patient is stable, and then you need to monitor him for next 7 days for reacclimatize the patient over 2 to 4 weeks. Next, please. Next, please. Next slide. So to summarize, we need equipment for emergency management, for rapid cooling, also supportive management, IV fluids, cardiac monitors and all. IV fluids, I may just add that giving cooled IV fluid, which may be of a temperature of 5 degrees to 10 degrees, may have only slight help and has not been generally recommended for as an additive measure. And next, please. Yeah. Previous slide, please. Okay. So this has already been said by Dr. One that we have to avoid dehydration, ask children to wear particular type of clothes, and also anticipatory guidances to the families regarding playing in the sun and all, everything like that, not living in closed space. Next, please. Next slide. Next slide. Sorry for that. So cooling infrastructure, as has already been shown to you, there are tubs, there are pools, there are basins which are available, which can hold cold water or ice, and there are ice cube preparation which can be done by various degree of fridge. Various types of fridge are available, and one available in RML produces 250 kg of ice cubes every 1 day. And the evaporative cooling can be used by mist spraying and industrial fan, which can throw air at the speed of 1 meter per second. And next, please. So this is a diagrammatic representation which has already been shown how to cool the patient. Next, please. So this is a case scenario where is a 7-year-old and has been diagnosed to having heat stroke. So most immediate next step in this child would be, next please. So initiate rapid cooling via immersion because it's a bigger child. So we can immerse him into cold water or cold ice and simultaneously take other measures. If he is conscious, then we allow sipping cold water and transport him. Next, please. Next. Next slide. So this is previous slide, please. No, previous. So पहले वाली slide. Care, anyways, there was another scenario which was mentioned before this reference, wherein a 6-month-old child was having a heat stroke, and the management scenario in this small kids would be to have a cold mist and a fan and cooling the cold temperature along with IV fluid and other things. I think this topic did not demand too much after two topics which were taken by the previous speakers, wherein they enumerated all the preparedness which is required, all the gadgets which are required, and I think I don't have much to add to it. Any specific questions I would be able to answer. Thank you.
Thank you, sir. Over to Dr. Pradeep, sir, for
Thank you, Dr. Divan. My question is, suppose uh, someone in the family found that the child is having high grade fever. Is there any government call to which hospital he should be taken, and any guideline for the public and any specific guideline for the hospital? Uh, if any such things, just please let us know.
The see,
Dr.
about
Abhishek,
2
would you
years
like
ago.
Dr. Abhishek, would you like to participate? Diwan sir, continue, please.
So what I was saying was, as Dr. Pradeep asked, the government of India, about 2-3 years ago, got very active on this issue of head heat stroke, and they had even held a workshop wherein they prepared a document about preparedness of for the heat stroke and various guidelines to be issued to public for how to, especially for kids and especially for various workers which work outside during heat, and also they wanted to announce when there is a possibility of heat stroke depending on the environmental conditions. So they will announce the various dangers which are whenever the temperature goes beyond 45 or something. Different areas, as Dr. Shaili had already mentioned, that for plains it is 45, for coastal areas it is even lower because of the humidity. So there are warnings which are issued by the government. Plus, they have made some certain guidelines for how to perform, how to act in during outdoors for children, for even the workers, for the even the athletes, and if they are conducting any mass program, outdoor mass program, wherein suppose marathon race or something, then they have issued various guidelines on the preparedness for that in view of the heat stroke. So those are about the government guidelines and the preparedness. Of course, then after that meeting, there was a setup which was done at RML, and they had advised a similar setup to be done at other major hospital in Delhi. And at RML, we have 4 such beds in adults where the management of heat stroke can be done.
Okay,
Yeah.
one question was there from Dr. Dinesh Singh, whether what should be the saline temperature that we infuse? Perhaps he has deleted that. What should be the temperature of the saline, that cold saline that we
Yeah,
are talking about?
the guidelines as such, as I said, the additive effect of giving a cold IV saline has not shown much, additional benefit. So the current guidelines have not any recommended any cooling of IV lines, but the research which has been done previously have done the normal saline temperature to be at 5 degree, and other different types of temperatures have been tried.
Okay. And some question from another audience. Can birth be given if no facility for immersion is available and child is fully conscious?
Yeah.
Yeah.
So as I said, it entirely depends on the age, because there is a risk of water drowning. So smaller kids are not to be immersed completely in water. But of course, if there is no facility for bigger kids, even like bathtub or
Give
a
bath and
collapsible bathtub,
use fan to cool
yeah,
them. Indeed. Okay.
yeah, mist
So,
and fan, yeah.
okay. Dr. GP Kaushal, sir, please, if you want to ask or
I think sir is busy in some parallel meeting. So
okay,
he just put the message to.
Dr. Sanjay and
Yes,
Dr.
sir.
I request Dr. Sanjay Singh, sir.
Yes, sir. Yes, sir. Good afternoon, everyone. Good afternoon. And
Yeah.
sir, very good topic you have taken, Dr. Vivek Dewan. Sir, actually, I am looking after
Yes,
as the
your voice
hospitals
is
as
breaking.
well as to other departments.
Your voice is breaking up.
And right now, 46 hospitals has told us that they have prepared the code room. Measures
Sir,
we can
your
take
voice is.
regarding the ambulance. Hello?
Hanji, Hanji.
Yes, yes.
Hello, am I audible, sir?
Yes, yes.
आपकी
Sir,
बात
my question is,
Yes,
what are the
now audible.
specific related to pediatric population, what are the specific measures we can take in the ambulances? We have written to the ambulance, CATS ambulance for the various measures, but for the point of pediatric population, what we can suggest them?
Yeah. Like I said, the fan is can be still be available in van, and mist can be prepared. Like they can be sprays, which can be held there available in the ambulance. Also, ice packs. Ice packs can be placed in axilla and all those things, even though they are especially not very effective. As used to be believed previously, that placing ice packs on the major vessels may be more effective, but they can continue to do cold sponging and mist and the fan, apart from giving IV fluids and all.
Thank you, sir. Thank you so much.
Okay. Dr. Surinder Singh Beast. Dr. Surinder, are you there? So one question is there from one audience about efficacy of suppository, paracetamol suppositories. Here we are talking not to use paracetamol, so it may be oral or injectable or suppository that will not work, I think.
No. See, the problem is that the whole phenomena starts with the dysregulation of hypothalamus.
Yeah.
So these things won't be effective.
Yeah. So now over to Dr. Shyam.
So, in concluding regarding that session, strengthening of the health system preparedness, that's the basically that the aim of this session. What are the things we should do before and during and after the warm session or that the summer session. So, in that have the pre-heat sessions in which we have the multiple preparedness regarding the procurement of the various instruments for the cooling, making the guidelines from the standard guideline SOPs to for the healthcare worker, including paramedical healthcare workers or doctors, and other things regarding the prepared purchasing of the various equipment. And during the heat session, we should make sure the format the one of the system that follow the guideline SOPs and give the effective outcome regarding the caring of the affected population. And after post heat session, there's some guideline to how to secure that instrument that purchase and use for during the heat session. Because once the heat session is over, we forget about the caring of that instrument. That is the mainly aim of this session. Thanks to all our faculties, our moderators, and our participants to join this program, because that program is very important, because World Meteorological Organization or Indian Meteorological Organization, they said scientifically proven in last few years death related to that heat related illness is suddenly increased up to reached up to 55% as compared to 20 to 30 years back, because due to the various factors, might be climate change, might be carelessness, might be inadequate preparedness. That's the various factors as we discussed earlier. So thanks to all, and I would like to thanks to Delhi government, Directorate of Family Welfare, government of GNCT to give the opportunity to IAP Delhi to help such an important health related topic. And I think we fulfill the requirement or demand of our participants, especially medical officers. And definitely after this activity, they give the more effective care to our pediatric population. Over to our SPO Child Health, Dr. Abhishek.
Thank you, sir, for supporting this program. And thank you, IAP Delhi, Shyam Sundar, sir, who has taken initiative in coordinating with all the moderators and key speakers for this session. And we also like this platform to disseminate the information that Stop Diarrhea campaign has also been launched in Delhi from 16th June to 31st of July. And the ORS and zinc corners, the key focus will be to give ORS and zinc, this two combination. And the theme of this is also the same, 10 की रोकथाम ORS और zinc के साथ. So thank you, Dr. Pankaj sir. Thank you, Shyam sir, for this session.
Thank you. Thank you all. Thank you. Thank you. Thank you.
Thank you, sir.
Thank you, Dr. Shyam. Thank you, Dr. Pankaj.
Thank you, sir.